All right, it is 12 o'clock, so let's go ahead and get started. Part 3, Chapter 5. This will be the conclusion of us working on Chapter 5, which is on mood disorders and suicide. So, a couple of things I wanted to talk about before I get into the treatment, just incidence and prevalence. How many people actually deal with mood disorders? It's a high number. According to the National Institute of Mental Health, I've got this written up here on the share screen. 2017, 9.5% of adolescents, roughly about 4.5% of adults, in 1 year experiencing major depressive disorder. We are not talking about depressive, clinically symptomatic depression. We're talking about major depressive disorder, like really serious depression. So that's a huge number of people. Millions and millions of people. That's nearly 10% of kids between 12 and 17 experiencing major depressive symptoms. That is horrendous. And this is something that is, a really huge problem as far as the ability for these people to, these kids especially, to function well in school, for these adults to be able to function at work. We're talking about nearly 1 in 20 people experiencing major depressive disorder. And it's even higher percentage of women than men. It is much more likely that women experience depression and anxiety, which is partially probably cultural, because it is a lot more acceptable for women to seek help. It's a lot more acceptable for women to express that they're having problems dealing with life, and women are more likely to actually seek out treatment, and the numbers are going to, reflect that. For men, men are oftentimes just less likely to seek out help for problems. They tend to self-medicate more often. Women do it too, so I don't want to, put anything out there that's not accurate. But there are certainly a lot of men who have, symptoms of depression and just don't ever talk about it. There's a lot more even percentages of people that have bipolar disorder as far as across the gender lines. So there's not a significant difference in the incidence of bipolar disorder between men and women, even though, women definitely get talked about as though we're bipolar more often because we have more, mood? I don't know. It's once you really kind of understand this stuff a little better, you go, no, it's the same. But women are more likely to experience depression because, well, because we're women. Number one, there's, we're pulled in more directions. Typically, women are expected to have the careers and the families and the stuff and the things, and it's hard. And that's causing a lot of women to have a lot of anxiety and a lot of women to have depression, and sometimes both. So you do have those kinds of things that contribute to the prevalence and incidence of these mood disorders. Again, not a significant difference with bipolar disorder, but it's a much smaller proportion of people who have bipolar disorder across the board. Now, as far as actual clinically significant depression disorder, the numbers are much, much higher. And I have been seeing these numbers for literally decades, that it's about a 1 to 5 ratio of people who have bipolar disorder versus a clinical depression. So 2.5 people, two and a half people, two and a half, what's a half a person? 2.5% of people roughly that have bipolar disorders at any given time, any given year. That's still a heck of a lot of people. I mean, think about that. What the population of the U.S. is roughly, 330,000 million people. So 1% of that's 33 million. So we're talking almost, we're talking about 10 to 12 million people who have bipolar disorder at any given time. That's a heck of a lot of people. So, I mean, that's more than the population of Arkansas, for heaven's sakes. So, these are things that are relatively common. It's certainly not unusual to, have someone in your family who's got one of these disorders. It's certainly not unusual to know people who have one of these disorders. Um, One of the reasons I went into this in the first place was because of having a brother who'd been diagnosed with bipolar disorder. So these are a lot of people that we're talking about here. So, what do you do about it? Well, you do different things depending on which side of the pole people are on. For the unipolar disorders, you are most successfully going to hopefully be doing some cognitive therapy. Cognitive therapy is therapy that works on changing people's thinking, which is kind of hard to do. But cognitive therapy works on the feelings and thoughts of helplessness, hopelessness, worthlessness, that things are not going to get better. The rumination that, especially for women, is just a huge part of maintaining depressive symptomology. It is a very common thing for women to just sit and think about something that happened in their past and replay it over and over in their heads and feel guilty about it and kick themselves for not saying something better at the time. We all do that some, and certainly plenty of men do this as well. But it is a more common thing for women to engage in this rumination that could just really do a great job of maintaining depressive symptoms. Men have more tendencies to use distracting things. Men are more likely to self-medicate. Men are more likely. Now, again, this is broad generalizations here, so it's certainly not one size fits all. But, in general, men are more likely to engage in this distraction. They're going to, go and use substances more often than women to distract themselves from their pain. They're going to do other things than just sit around and think about all the crappy stuff that's happened to them. And, well, not to put too fine a point on it, women oftentimes have more crappy stuff to think about and more crappy stuff that happens to them. We're much more likely to be victims of sexual assault, violent crime, all kinds of stuff like that. So it is part of, just our lives that we have bad things happen to us like that. That is not nearly as common for men. So that's an additional thing that can cause that rumination to be more prevalent. Also, when you're talking about changing the way people think, one of the things that you're wanting to work on is reframing, helping people who have depression see that the way they're looking at the world is distorted. The way that they're looking at the world is irrational. The way that they're looking at the world isn't accurate. Because one of the big things that is going on with people who have depression is this distortion of reality. It's not delusional in the way that you think of someone who has schizophrenia being delusional, is just like completely out of touch with reality. But they are looking at a really funhouse mirror version of reality where it all sucks, where it's all really bad. And they have a hard time seeing the good that's in the world. They have a hard time seeing that things will get better. And always change is a part of life. Always. No matter what's going on, good or bad, this too shall pass. And helping people see that is one of the most valuable things that you can have in therapy when you're talking about people with depression, especially, is to see that yes, things suck right now, but they will get better. And then they'll get worse again, and then they'll get better, and then they'll get worse. Life is a bit of a roller coaster. We do have those ups and downs in life. And one of the best things you can do for, dealing with them is to realize that this too shall pass. Enjoy the highs. Don't get too caught up in the lows because it's not going to last, generally. So that's a big part of doing the cognitive therapy. Of course, I already talked about ECT, or the electroconvulsive therapy. This is the medical intervention where you actually put electrodes on someone's head and proceed to shock the bejesus out of them. And you are inducing a seizure. that basically does almost like a short circuit in their brain and kind of resets things. It's almost like a reboot. I mean, that's not completely accurate, but think of it in terms of like rebooting your computer. For a lot of people with unrelenting depression that just has not responded to anything else, ECT can actually help. Now, we're talking about numerous rounds of treatment here. We're not talking about a one-time thing. It's usually 3 times a week, twice a week for 2 weeks, 3 weeks, up to 7 weeks. Memory loss is a real common thing, as I mentioned, with ECT. So it is not the first line of defense by any means. It is after you've exhausted all the other possible treatments for depression. But for some people, it's an absolute lifesaver. For some people, it is just the world of difference for them. So that is something that can be done as kind of a last resort treatment. One important thing I do want you to know about the medications, they generally take at least a month before they take full effect. So I highly, highly always recommended to my clients, it's like, give it time. Give it time. Don't take it for 2 weeks and then go, well, it's not working, and stop taking it, because it takes a long time. We're talking about, things that affect your brain chemistry, neurotransmitter levels in your brain. So it's not something that happens overnight, nor would you want it to be something that happens overnight generally, because you're messing with some, pretty complicated systems there. So with the medications, again, you just have to give it some time. And you also need to taper off whatever you're taking to start taking something else. So that's another thing. You don't want to take these antidepressant medications and then go cold turkey and stop taking them. You need to taper off of them over a few weeks before you try something else. So this is not a quick fix. This is not short-term treatment. When you're talking about treatment for depression, it's going to take time, and it's going to take a lot of time. So the medications take 4 to 6 weeks to take full effect. And once you get improvement enough, you are going to be on these medications for at least 6 months before you generally are going to get off of them. It's much more common for people to be on them much longer than that, but 6 months is like the bare minimum for most folks. And when you are on a medication, it's not really working, you still need to give it some time to get off of it. You need to lower the dosage week by week before you get off of it and try something else. So again, you're talking about a couple of weeks to get off something, then you start something else, you start the timer over 4 to 6 weeks. So yeah, it's time consuming, and that's not great because people are suffering in the meantime. But it's the safest thing that we can do to not mess with your functioning even further than the disorder's already messing with you. So 3 main types of antidepressant medications that are commonly prescribed, and these are in descending order of popularity. The SSRIs, of course, are the selective serotonin reuptake inhibitors. These Prozac, Paxil, Zoloft, Celexa, Luvox, there's others. But these are the drugs that manipulate levels of serotonin, the neurotransmitter that helps regulate mood in your brain. And these originally, Prozac came out in the 80s, in I think the mid-late-ish 80s, and it was touted as the end of depression. It's gonna fix all the depression. It was on the cover of like Time magazine or Newsweek or something. I remember the picture of the pill, the two-tone green Prozac pill, and it was gonna just cure all the ills of society. Obviously it didn't, but have they been a game changer for a lot of people? Yeah, they have. Serotonin is just one of literally dozens and dozens and dozens of neurotransmitters that we have in our brains. It's one of the ones that influence our mood. There are other neurotransmitters that also influence our mood. There are some other medications. I think I mentioned last week. There's a drug called Effexor, which is an SNRI, which affects norepinephrine in your brain, which again is a mood regulating neurotransmitter, which can be helpful for some people who don't respond to the SSRIs. There are, drugs that influence both serotonin and norepinephrine. In fact, effects are maybe one of those. I'm not absolutely positive, so I'm not going to say. Um, but these drugs are very helpful for about 60% of people who take them, which is not awesome level of effectiveness, but their side effects profile is relatively manageable, although it's not great. One of the most common side effects for SSRIs is that it kills your sex drive. If you're single and you're not particularly enjoying your sex life as a single person, or something of that nature, you're not in a regular, I don't know, yeah, gee, I'm trying to think of the right term for it. If you're not in a friends with benefits situation or something like that, it may not be that big a deal that it kills your sex drive. If you're in a relationship, yeah, it can absolutely mess with things. I mean, you're already having problems because of your depression, and then your sex drive goes away, and that thing in your life gets kind of squashed down. So yeah, that can be a real problem. There's also weight loss and weight gain that can go with SSRIs, and depending on the individual person, that could be problematic as well. But one of the key things about the SSRIs is that they're really, really difficult to overdose on in a way that would really cause long-lasting harm. Now, you can get what's called serotonin syndrome if you take too much of these drugs that can make you feel really lousy, but it's not going to just kill you the way some medications can. I mean, there are some medications that people take for various psychological problems that are really, potentially dangerous. It can straight up kill you. So there is that aspect of it. Again, the SSRI has been around since the 80s, so they've been around for good 35 years now. So these are not new by any stretch of the imagination. Tricyclics have been around considerably longer. I think they hit the market in the 50s, so yeah, they've been around a very long time. They're cheap as dirt generally. There's those $4 prescriptions for the most part, especially if you get the generic forms of them. Imipramine and amitriptyline, tofranil and Elavil. These drugs have about the same efficacy or the same results as the SSRIs. It's about 60% effectiveness. And the side effects of tricyclics are worse in general than they are for the SSRIs, in that it's fairly common for them to cause constipation, which is not great. It's fairly common for them to lower your blood pressure, which may or may not be great. If you have slightly elevated blood pressure, that could be a good thing. Blurred vision is a semi-common side effect, so that's definitely not a good side effect. Drowsiness or sedation is also very, very common with these drugs. When you have someone who is experiencing both depression and anxiety, this could be actually the right choice for them. Absolutely. Because if you've got someone who has both anxiety and depression, then the slight sedative effect can help with the anxiety part. The mood lifting effect can help with the depression. So these drugs can still be very, very useful for people who have both, anxiety and depression. And that is a relatively common thing. I mean, it's not common as, the one or the other, certainly not as common as anxiety disorder symptoms, but it is still pretty common for people to have both. So these are absolutely useful medications for those individuals. And then we have the MAOIs. MAOIs are called that because monoamine oxidase inhibitor. Kind of a mouthful. I mean, selective serotonin reuptake inhibitors is a mouthful too. That's why we call them SSRIs. MAOIs are a class of drugs that have been around, again, a long time, since mid 20th century. These are not as good as either the tricyclics or the SSRIs, so they're not prescribed nearly as often. However, they do have some pretty good efficacy for some people who don't respond to the SSRIs or the tricyclics. But they also additionally are useful for some people who have anxiety disorders and especially panic disorder, especially those who can't take like the benzodiazepines because they've got like family history or substance abuse history of problems with drugs. These are drugs like phenelzine, isocarboxazid. Yeah, it's kind of a mouthful. But Nardil and Marplan, is what the name brands of them are. Um, the weirdest thing with MAOIs is they require you to alter your diet pretty significantly for at least some of us. I mean, I know if I had to take these, I would have to alter the hell out of my diet. You can't have like soy products. You can't have soy sauce. You can't have like you can't eat edamame. You can't have soy. I have soy powder in a freaking smoothie every morning, so yeah, I couldn't have that anymore. You can't drink red wine, beer. You can't have chocolate. Oh my god, ugh, that would cause me to be depressed. Just that all by itself. The cheeses, like aged cheeses, you can't have like blue cheese or Parmesan cheese. So a lot of different kinds of cheeses that you can't have. Basically anything that has the amino acid tyramine in it in large amounts. And tyramine is an amino acid tied to a protein. And with these MOIs, they interact and can cause a dangerous spike in your blood pressure. So, like, send you to the ER, potentially give you a cardiovascular event kind of thing, raising blood pressure. So, that is definitely a rather nasty side effect. And for a lot of people, the inability to eat some of those foods is just really problematic. Um, you know, if you have a diet that is heavy on soy products, if you are vegetarian or vegan and you eat and that's one of your main sources of protein, obviously that's going to be a big problem for you. If you are adhering to a largely more kind of Asian typical diet, this is not going to work very well for you not being able to have soy products. A lot of different things like that that can interfere. And for a lot of us, just not being able to have chocolate or a glass of wine or having a beer or something could be an issue as well. So MAOI is not nearly as commonly used, but they do still have some uses for some people on that. But medications are so often first line of defense for people with depression. They go to their regular PCP doctor, their primary care physician, and they tell the doctor they feel lousy, and the doctor writes them a script, and that's the end of it. And they take the pills, and they still feel lousy, and they just keep taking the pills, and then they go, this isn't really working, and the doc writes them a prescription for something else. And it goes on and on and on. And as I mentioned before, there's a lot of people who have depression because they have a biochemical imbalance in their brain chemistry. There are also a lot of people who experience depression because their lives are just a big bag of suck right now, and it's not going to be helped by medication. It's going to be helped by changing something about your life or grieving the loss of something in your life and processing that. And it just takes time for some of these things, and popping a pill's not necessarily going to be a shortcut for you. So you need to see a doctor who specializes in this kind of stuff if you can. It's much better to see a psychiatrist if you can. I know it's not possible for everyone. It's certainly important to get a therapist that can help you sort through some of these things, kind of help you determine if it seems like it's more of a situational type of depression or a biologically based type of depression. Because there's certainly plenty of things that we can help as therapists that may not necessitate the need to take medication, or at least get you the best possible kind and dosage of medication for you for your particular situation. And so again, I would always recommend anyone who has a serious like major depressive disorder diagnosis to be getting regular therapy, to be seeing a psychiatrist for their medication management rather than their regular physician. Nothing against regular physicians, but that's not their area of specialization. If you break 7 bones in your foot, you probably ought to see a podiatrist to take care of your foot because that's the area they specialize in. If you have cancer, you should see an oncologist. Well, if you've got, mental health issues, you should see someone who specializes in treating mental health issues. So there's that. And of course, that goes with, virtually any disorder. Bipolar disorder treatment, the first line of defense is not going to be therapy, as often with people with bipolar disorder, because they need medication to get the manic or hypomanic episodes under control. And the most common medication, it's an oldie but a sort of goodie, lithium. Lithium has been around for many, many, many decades. It's very, very inexpensive. It's also kind of problematic in that lithium can build up in your system, especially in older folks. People who are like over 50, 60 need to have even more monitoring because your body doesn't just clear that stuff out as quickly as younger people do. And it can become toxic. It can build up in your liver. So blood tests regularly are part of having lithium therapy for bipolar disorder, and that's not the best thing for a lot of people. It can be just at best, it can be kind of a nuisance, and at worst, it can be just yet another thing for them to have stress in their lives over. There are also anticonvulsant medications that are given to people with bipolar disorder. These Tegretol, Depakine, Lamictal, anticonvulsants are drugs that are normally used to treat people who have seizure disorders. But for people especially who have rapid cycling, which again is 4 or more times a year of the ups and downs of bipolar disorder, these drugs can actually be quite useful. One thing I would say, Lamictal has it's an unusual side effect, but it's a doozy. In very rare cases, thankfully, very rare cases, it wouldn't be on the market if it was common, but it can cause you to have a really nasty rash that can cause your skin to basically bubble up and peel off in sheets. I don't know about y'all, but that sounds kind of nasty. I wouldn't want to have that happen to me or my kid. I actually worked with a kid who was only 10 years old, and they had him on this stuff because he had been wrongly diagnosed with childhood bipolar disorder, and somehow some doctor had written a prescription for Lamictal, and I was absolutely horrified. The kid did not have bipolar disorder. He had some mood issues. He had reason. I won't go into details on that, but he had some damn good reasons to have the mood issues that he had. He had some anger issues. Lots of kids do. But this drug is one that I would definitely be kind of leery of myself. Tegretol and Depakine both are, don't have side effects like that. So those would be the ones I would try first. For sure. But again, this is more for people who have the rapid cycling type. Now, that being said, in both depressive disorders and bipolar disorders that are really, really severe, you can have people who get so sick, basically, that they become psychotic. And in those rare cases, even for bipolar disorder, it might be appropriate for them to be on relatively low doses or very low doses of antipsychotic medication. Again, I ranted about how much I hate that antipsychotic medication is being advertised as an adjunct or an addition to your antidepressant medication for people with just regular, depressive disorders. And it ticks me off because these drugs are so incredibly powerful and fraught with really serious side effects potentially, like tardive dyskinesia, which is a movement disorder that is permanent. The type 2 diabetes, extreme weight gain, like 20, 30 pounds in a month kind of thing without changing your diet or exercise. These are, major issues with these medications. But for some people who have bipolar disorder, the antipsychotic medications can really, really help them. For some people, very small percentage of people with depression that is so bad that they become psychotic, it can be very helpful. But again, it's a very, very, very small number of people in either situation. So just, again, it just irritates the crap out of me. when I see these ads on TV and ads in these magazines making it sound like, well, if your antidepressant's not working, just add Abilify to it. That's great. It'll just help. It'll be better. And, it's super expensive. The side effects are gnarly as hell. And they're still talking like, oh, well, if you still don't feel good, just take another pill. Oh, you don't feel like folding your laundry? Just take some Abilify. Then everything, the laundry will practically fold itself. No, it won't. And that's hardly the issue. I mean, the ways that it's shown. I mean, we're talking about the advertisement showing a woman always at work, functioning, not feeling good, but functioning. That is not the kind of person that would be an appropriate candidate for adding an antipsychotic to their antidepressant medication. So it's just so misleading, and it just irritates me to see that, because I know there are thousands of people who look at those ads and they go to their doctor and they end up with a prescription for this stuff, and it ends up screwing their lives up because it messes with their health. I mean, to have type 2 diabetes because you just felt kind of bummed out is not a good trade. To have type 2 diabetes to stay out of a mental hospital, still not not the best scenario, but, for a lot of people, it's worth it. But, not just because, well, I don't feel good. So there's that. The types of psychotherapy that are the most helpful for bipolar disorder. Cognitive behavioral therapy is pretty much the go-to for most disorders, but especially when you're talking about people who have bipolar disorder, helping to recognize the ups and downs can be one of the most valuable things you can do for someone who has bipolar disorder, because that can help them head off some of the deeper lows and higher highs that can cause trouble for people. If you can help them recognize their own ups and downs, and when they're heading into a manic episode or heading down into a depressive episode, they can get an appointment with the doctor and the psychiatrist, hopefully, and maybe tweak their medication to see what can be done to help. And they can, maybe see their therapist more often. And again, as I said before, anyone who's been diagnosed with bipolar, especially bipolar 1, but bipolar 2 also wouldn't be a bad idea, to have a therapist that they see like once a month, just once a month, one session a month. And even if it's just a short, like 30-minute, we can do telemedicine now. I mean, the rules have changed on a lot of stuff. So you could sit down at home and have a Zoom call with your therapist and just to check in, and they know you. Hopefully you'll get a therapist that you jibe with really well, and that you will be able to have a close enough, working relationship with them that you can have them also notice when you're on an upswing or a downswing, and help you notice that, so you don't have those severe relapses that are unfortunately fairly common for people who have bipolar disorder. And that regular feedback from another mental health professional can be really helpful. There are lots and lots of people who have bipolar disorder that function quite well. There are lots of people with bipolar disorder who have great careers, who have good, lives. Do they need to have medication? Yeah, most of the time. Do they need to have regular, mental health appointments? Yeah, usually. There are lots of things. If you Google, celebrities with bipolar disorder, it's a long list. Now, I'm sure most of you are aware of who Carrie Fisher was, the Princess Leia from Star Wars. Years ago, my husband and I used to watch Craig Ferguson's Late Show, and he had her on the show, as a guest, and she was clearly ramping up into a manic episode because she was all over the place. She couldn't follow a train of thought. She was talking super duper fast, and she was usually a really funny, guest on the show. They had a real good chemistry between them. And, we both kind of looked at each other going, well, bet she's going to be in the hospital the next few days. Hopefully not something worse. And sure enough, like 2-3 days later, saw in, news that Carrie Fisher's been checked into a residential treatment facility for her bipolar disorder. Yeah, it happens. But you're also talking about someone who was extremely wealthy, had an amazing career. I mean, even aside, she did more like screenwriting work than acting, but she did some, pretty notable acting work as well. But, there are lots and lots of people who have these issues and they manage to work around them. Catherine Zeta-Jones has really severe bipolar disorder. So there are a lot of people who, deal with this and deal with it well and still have, a relatively normal life. It's a problem that they have to deal with. Like you have a chronic health problem you have to contend with. You have a chronic mental health problem you have to contend with. But, the people who have either, either the depressive, either what are called the unipolar, which is the depressive disorders, or the bipolar disorders, as long as you are, taking your medication and it's helping, then great, then keep doing that. But it does, it takes time, even also for the bipolar disorder medications, it does take time for them to start working. So that is something else for people to consider. Don't expect it to help the way, like, that's one of the things like benzos, like benzodiazepines for anxiety. I mean, they start working within like 20-30 minutes. Like I know Xanax is one of the faster acting ones. It is. If you put it under your tongue, it'll start working in like 10-15 minutes. So, no, you don't get that kind of thing with antidepressants. It takes weeks, and that is a hard thing. But it is generally going to be worth it for people. So, just have that in there. For the rest of the week, you've got an assignment here in Canvas for Friday. Obviously, Labor Day. We are not going to meet on Labor Day. I do have, if you want to look ahead to Chapter 6, which is on anxiety disorders, I do have the videos for you to watch, but I do have some links at the bottom of that assignment for some breathing exercises, for some deep relaxation exercises that are videos on YouTube. So if you are a person who does struggle with anxiety, I highly recommend that you check that stuff out and maybe, do a little investigation on your own, because that can be absolutely one of the best things that you can do. Is have that in your repertoire of ways to chill, to get your anxiety to be blunted down a bit. And again, we will not meet in person on Monday. We will have Zoom next Wednesday, and then the following Monday we'll meet in person again. But just be sure, because if you come to class on Monday, I won't be there. So y'all have a good weekend. Have a safe weekend. Please, be careful out there, because the COVID is still just what it is. So do be careful, especially if you're not vaccinated. And if you're not vaccinated, go get vaccinated, please. So there is that. So y'all have a good one, and we'll see you next week.